This patient has an airway obstruction. Their GCS is lower than 8 and a verbal response of lower than 2. So I'll be inserting an OPA into their oropharynx. The sizes of the OPAs come in triple 0 to 5, and you measure the OPA from the top of their mouth to their mandible. You insert it posteriorly into their mouth, twisting it 180 degrees to the top of their lips. The indications of them not accepting it is induced vomiting, damage to their oropharynx, and worsening their airway obstruction. And then you just check to see if they've accepted it properly. I'm going to use an NPA because I can't use an OPA because the patient has a gag reflux or too much vomiting. I'm going to only use this, an NPA, if the patient has a high GCS or trismus. I measure the NPA from the nostril to the mandible using the larger nostril. I'm going to put water-based lube onto the NPA and insert it 90 degrees from the patient's face down until it rests on the nostril itself. If resisting, I can turn the NPA 180 degrees, or you can remove the NPA itself and use the other nostril. Wouldn't use an NPA if the person has a base skull fracture, and complications from using an NPA are excessive bleeding or having nasal polyps. This patient has a airway obstruction. To clear that obstruction, we're going to use the suction kit. We're going to test the suction kit first to make sure that suction occurs. Turning it on, occluding the tube, the pressure is rising, which means that suction will occur. In the suction kit we use a rigid catheter. We don't use a rigid catheter in a moving vehicle, instead we'd use a soft catheter. We place the patient into the lateral position or the recovery position. We're going to insert the catheter only to as far as you can see, and closing the circuit only on suction on the way out. In a circular motion, we're going to go for less than 10 seconds so that suction occurs and we don't have any complications such as induced vomiting, the induction of brachycardia, hypoxia, aspiration, and no soft tissue trauma to the patient's mouth or laryngeal spasms. This is the LifePak 12, and I'm going to do an ECG and monitor familiarization with this monitor. I'm going to turn it on here. LifePak 12. Turn it to minimize so that it doesn't talk over the top of me, and also at the same time turn it down to 50 dOLs so that when we do our test charge, it only goes to 50. Right, I'm going to go across and do a user test. And user test in progress. While that happens, I'll show you that in here is the defib pads and leads and GTN, aspirin, shaver, anything you can use for that. And back here is the blood pressure cuff. Behind that is the batteries. Both batteries you check to see if they are full and ready. They are. And this one is the SpO2 board, which you stick onto the patient phone bell like so. ECG, as we're sticking on now, the simulation. This is the carbon dioxide detector board, which connects into here and connects to the bag glove mask. Yep. Right, now we'll just wait for the test to finish, which is exciting. And you just check to see that it's the correct date and correct time, which it is. So what I'm going to do now is check the leads and change here to here. Let's check, turn it on. So that works all fine. Let's change the size of the leads there by pressing size. Change again the leads like that. Down. Next, QRS volume. We go across to QRS volume here. Press it again. Turn it up here like this. Change to see if it's papered all in there like that. It's full. Ready to go. Right, we can actually get it off. So we're good here. We're going to do a test charge, or test shock, sorry. So press charging to 50 dOLs. Tell me to shock, so I'll press shock. Energy is delivered. We'll charge it again to disarm. Disarm by pressing here, and that's disarming. We'll put it back into automatic mode, which is
analyzing now. Stand clear.
Into here.
No shock advised. Start CPR.
Start CPR. Right, this is the blood pressure button here. Just to check the blood pressure. It'll be on the patient's arm. is the wrist. Like at 12. Okay, so this patient is complaining of leg pain. So before I do anything, I have to gain consent. Hurt yourself.
Well, I was playing soccer and I kind of got tripped up and just fell really awkwardly, and now it's really sore.
Yeah, and which leg is it?
This one, and kind of like down about there.
Okay then. Is it okay if I take a look at your leg?
Yeah, sure.
So I'm just going to pull it up, pull up your pants and just have a look, and then also compare it to your other leg.
Okay.
So I'll just try and do it gently, just let me know if I hurt you too much.
Okay.
Alright, so I'm just going to look for cardiovascular and neurological integrity by comparing the two colours of the feet, the pedal pulse on top here, capillary refill, and also the touch, like the temperature. And can you push your foot? Yeah. And how about on this one?
Yeah, just a bit more sore.
Okay. And can you wiggle your toes for me on the side? Okay. Yeah. So from the history and the plus discs, I can pretty much determine that this is a tip of fracture. I'm just going to ask her now what kind of pain she's in from 0 to 10, 10 being the highest and 0 being the lowest. What kind of pain are you in?
I'd say 7 or 8.
Okay then. So with that, and her pain being high, I can administer some Entonox. And this pain relief is an inhaled analgesic. It's self-administered. It's 50% oxygen and 50% oxygen oxide nitrate. Yeah. So, but before I do give you anything, I just need to ask you a few questions. Do you have any chest pain actually at the moment?
No.
No. And have you been diving in the last 24 hours?
No.
Any bowel obstruction?
No.
And any allergies actually?
No.
Okay, so, and you're able to talk to me, so I don't really suspect a pneumothorax or anything like that.
Okay.
Okay, so this generally comes on in, this generally comes on in 2 to 5 minutes.
Alright.
But you have to keep breathing in for it to work. So if you could just breathe in that
Okay.
really deep. How are you feeling?
I can feel it starting to work now. The pain's getting much better.
Okay, cool. Breathe in a little bit more because 6 to 8 breaths is actually better.
Yeah,
Alright.
feels pretty good.
Okay, and how do you feel now actually on a pain of 0 to 10?
It's probably like a 2 or a 3 with this.
Alright, so with that actually, I'm going to splint your leg.
Okay.
With this kind of a tip of fracture, it's probably best to use a box splint. So this is a box splint. Yeah. If I can get a bystander to come and help me, if you could lift the leg from here to here. That's good. Thank you. Lift it up for me, and I'll just slip this under like that, placing it in gently. Alright, and with a few other towels I'm going to support it. Just keep breathing on the Entonox for me so that you can...
Okay.
Yeah. So put that in gently on either side to support it, and always make sure that the fracture is open. Okay, well, it's open, but supportive and not moving and not covered up.
No, it's not too bad.
Just keep breathing in on the Entonox for me. I'm going to lift this up and actually just go right to the bottom here, my top. Always putting these tri-bandages above and below the fracture. That it's stable I'm going to reassess her neurological and cardiovascular integrity. So if you could just, again, that's all good. And can you wiggle your toes still a little bit? Yeah. Looking at the colour and the warmth and the pedal pulse and the capillary reflow. How's your pain actually?
It's pretty good with this. Yeah.
Okay then. So we'll just keep you on that, and now we're ready to escort you to the hospital to do some more observations. Alright, so we have a patient here and I'm just going to give her a history and see what's happened. What's happened here?
So I was up on a ladder and I fell about 2 meters high and landed here.
Yep. And using from a fall and stuff, we do the nexus rule. So I'm just gonna, before I do anything actually, I have to ask for consent. So is it okay if I do a few, like palpate the back of your neck and things and just see what's actually happening further?
Yeah, sure.
Cool, so using the nexus rule is we'll palpate the back of her C-spine midline to look for midline tenderness. So how's that?
It's pretty sore, yeah.
Okay. And then I also ask for like a neurodeficit, like if there's any tingling or numbness in her extremities, like her fingers and toes. So is there any numbness or tingling in your toes or your feet or your fingers or hands?
Yeah, and the front of my hands and my feet are kind of numb.
Okay. And then from that, I can also ask her if she's had any alcohol to drink today.
No, I haven't had any.
No. And she's clearly responding to me, so she's quite alert. Also need to ask her if she's got any other distracting injuries that she could think of, you know, that could be taking the attention away from her actual neck injury, possibly. Have you had any other, is there any other injury you think that could be distracting you?
No, I don't feel sore anywhere else.
Okay. So from that, I am going to use this C-collar, and so I explained to her the procedure of what we're going to do and what it actually is. So this is a C-collar, just to stabilize your neck, because I feel like you've actually hurt your spine and your neck, so we need to be able to put it around your neck so that we can transport you. I'm going to get my offsider to come and help me and come stabilize my head. Her head. So if you could just stabilize the neck, make sure it doesn't move anywhere. We're going to use our fingers to measure how high her neck is. We just measure 3 fingers. And then I just tell her, you know, exactly what I'm doing the whole time. So I'm just going to place that here like that, and then I'm going to bring it round underneath. Obviously not to move her at the same time. Obviously it's hard underneath. Everything lying on the ground, and then securing it. Is that all right? Not tight or?
Yep, it's not too tight.
Alright then, and then after we've placed it on her, we just inform them that we're going to we'll probably scoop her out on a scoop stretcher and put her into the back of the ambulance and transport her. This is a scenario on how to deliver oxygen. This is a compressed air, but for the purpose of the scenario it's okay, but you generally will be using pure oxygen. To administer oxygen you need a regulator. When attaching the regulator to the tank, you'd have a look to see if the Bodak seal is actually intact, which this one is intact fine. You put it on, and then tightening quarter turns until it's finger tight. Then you turn on the pillar valve, checking if the bottle's full. This one's just over 2000 psi, so not quite full, but good anyway. And then you check to see that it's going up in pressure with each turn. And it should get louder at 15 litres per minute. So we'll just, that's all good. Lying this down. So after we've done that, we're going to use a Hudson mask. We attach this here like that, this tubing, and then attaching it to here like so. Making sure it's tight. When administering oxygen, it's always between 6 and 8 litres. So we'll turn this on. Just now we'll put it at 6. And then you place it over the patient's mouth and nose, making sure it fits gently and snug over the top. And that's how you deliver oxygen. When not delivering oxygen and you turn it back off, the other way, disconnecting the tubes, closing the pillar valve, and then flushing out the oxygen until it's no longer about, turning it back to 0, and then placing the oxygen back down onto the ground. I'm now going to show how to ventilate this patient by using a bag valve mask. This is the bag that we use. We occlude the end here and push on it just to check that no air is coming out here because we don't want any backflow. So that's fine. Next we'll attach everything and test out the reservoir. Making sure it's attached well. Filter, mask, tube, which attaches to the oxygen here, but for this scenario I'm using compressed air because we don't have any oxygen, which is fine. We then turn it to between 10 and 15 litres a minute, and always place it back down on the ground. And just looking at the reservoir bag to see if there's any leaks or anything like that. Before ventilating the patient, we need to use an OPA. Inserting it in posteriorly, making sure not to catch the tongue, turning it 180 degrees and placing it at the top of their lips. Going to use a C-grip and place the mask over top of the nose and the mouth, holding their chin in place and tilting their head backwards. We're going to ventilate every 5 to 8 seconds, looking for good chest rise. And making sure that they are ventilated well and always holding the grip tightly. Complications of this is a gastric inflation. In that case I'd get my fellow officer or a bystander to give cricoid pressure. I have a patient here and I'm going to take her vital signs, but first of all I need to ask for consent. Is it okay if I take your vital signs?
Yeah.
The vital signs are going to include her pulse, her rest rate and her BP. When I take her pulse, at the same time I'm going to do her rest rate. How I do the pulse is on her radial pulse, which is on her radius, which is on her thumb side. It's about 2 fingers down from the bottom of her wrist, and I always use 3 fingers. So I go for 15 seconds and times it by 4, and her rest rate is the same. I count her rest rate for 15 seconds and then times that by 4. The normal pulse is between 60 and 100 beats per minute, and the normal rest rate is between 12 and 20. So for her pulse I'm also looking for a strong and regular beat, and her rest rate I'm looking for volume and clarity. Her pulse rate was 20, so times that by 4, and it was 80, which means she's in the normal range. And her she breathed 4 times within the 15 seconds, so times that by 4, and that's 16, which means she's again within the normal range. Everything was clear, everything was strong, everything was regular and clear. So now I'm going to take her BP, blood pressure. Is it okay if I put the blood pressure? Yep. I'm just going to roll up your sleeve here. Blood pressure cuff. Adult size artery goes on the brachial artery here, the inside of her arm. Bring the blood pressure cuff on nice and tight, making sure. Yeah. And then we feel for the brachial artery. Pump it up so the cuff is nice and tight so we can get an estimated systolic reading. Yep, so that was like 120. So the normal systolic reading is below 140 and a normal diastolic is below 90. Systolic is when the blood, we can no longer hear the blood flowing, so the brachial artery is cut off, and then diastolic is when the cuff is loosened off and the blood is flowing and relaxed and you can hear. So from the estimated systolic reading, I'm going to pump the cuff to higher than that so I can get a good reading of her systolic. And I'm going to listen for that closing off of the brachial artery. I can't hear it anymore, so I'll gently release it until I can hear the beat again. Which is at 110, so that's her systolic reading. And I can hear it nice and clearly, and it eases off, which means it's all relaxed at 90, which is her diastolic. So 110 over 90, which is nice reading and normal. This patient has a laceration to his arm, so we're going to use hemorrhage control to stabilise him. So you first of all want to expose the injury, do it so carefully because you don't know what's underneath. And there's a laceration here. So what you do is you get some saline and you clean out anything that's like foreign bodies or anything like that. Just clean it all out as much as you can. You get some a gauze swab, and fold it to however large it is or short it is, and you also want to moisten that with saline as well. So you put it over the laceration, you get combine dressing. And so you put the combine dressing over top of the gauze, and then you want to bandage it to give good solid pressure on the bone. So every time you go around, also to make it more pressure, you can twist the bandage round in 180 degrees each time you go around, just to give it that more stability and pressure on the wound. No blood's coming out, nothing's leaking, all the lights, just look at it, see if it's all good, and if there is anything wrong, just ask the patient to elevate their arm. In an emergency situation, if there was more blood or anything like that, you could use an emergency tourniquet. How you use it is you place it over their arm, and then you place it 10 centimetres proximal to the wound, so yeah, there, and you want to tighten it around their arm quite tight. And then you use the stick here to twist. And then you want to just strap it over like that and write the time, document the time. Before doing that, you also want to take the pulse and then distal, and then until the bleeding stops. And if the bleeding hasn't stopped with the tourniquet, then you want to tighten it a little bit more. And that's hemorrhage control. Okay, so we're entering a scene where the patient is unresponsive. We're going to check for any dangers, making sure that the scene is clear. And then once that's been seen to, we can enter the room and start our shenanigans. I'm also going to call out to the patient. Hello, sir. Are you okay? I can see that he's unresponsive, so I'm going to ask my offsider to come around to the other side. and place all the equipment down in a nice orderly fashion. Right. So again, I'm going to check his responsiveness. Hello, sir. Are you alright? And also checking his airway, see if anything is clear. From that, I can tell that he's probably going into a cardiac arrest. So I'm going to ask my offsider here to call for backup. Backup at R50 for an R49.
Can I get R50 back up for an R49?
So I've already done his airway and his breathing, which means now I'm going to ask my offsider to start compressions. Noticing that she does a good depth rate and can see the recoil back on the chest. Making sure also that she's doing it right all the time. While she's doing that, I'm going to get out the defib here and working around her. I'm going to turn it on now.
Analyzing heart rhythm. Do not touch the patient. Shock advised. Charging. Stay clear of patient. Deliver shock now. Press the
I'm gonna
orange
press
button
the orange
now.
button. Here, shock.
Shock delivered. Pause. Start CPR.
And I'm going to ask my offsider to hop back on the chest. So after that happens, I'm going to start trying to get the airway going again. And this is done by using an airway adjunct like the MPA or the OPA and using oxygen. Oh my gosh. Bit niggly. Can you just let me know when you're at 25?
Sure.
If I'm not ready with the oxygen kit, can you just keep going? So it's better to keep going on the chest if I've even not finished with my airway. So this is an OPA. Thank you. And I'm going to measure it from the from the mandible to the top of the mouth. Placing it in posteriorly and twisting it 180 degrees to the top of the lips. Rate of between 10 and 15. Yep, just pop off the chest there. Doing 2 breaths and looking for good chest rise. And getting her to keep going for 30 more compressions while I'm doing that. Also having the suction kit here just to make sure if anything happens and they come back to it. We can suction it out. Going to wait for the AED.
Stop CPR. Analyzing heart
And this
rhythm.
time we're going to come round and swap.
Stay clear of patient.
Because after
Analyzing heart rhythm. No shock advised. Pause.
that amount of time on the
If needed,
chest,
start
it's
CPR.
hard to keep going. Back on the chest as soon as possible. So 27, 28, 29, 30.
1, 2.
You ask in that time any history from if there's any bystanders around, things like did anyone see what happened, does anyone know the patient, and just trying to get as much information as you can.